All right, good evening, everyone. It is so great to see each and every one of you. Myself, Erin Das, a palliative care nurse from Canada, along with Tebello from Starlight, Oasis of Hospice, are really so excited that you are with us here today. We have been working really hard, as you have as well, to get connected. We've had over 108 participants register to our ECHO account. And we're really, really excited for what the next few weeks holds. Today is our launch day. So we have a few housekeeping items, which are really, really important. We need to acknowledge and thank people that have been involved in this course and preparing for it, as well as people that are partnering with Starlight, as well as PallCHASE. So we wanted to do that now. We then, just so you know, the schedule for the rest of the next about 1 hour and 30 minutes, we then will go into a bit of the history of palliative care in Lesotho. That will be led by Tebello. Then Joan Marston will be giving our lecture for today, and it's an introduction to what is palliative care in a limited resource setting. We then will have time for discussion, so you can put some questions in the chat if something comes up during those times. If not, we will also allow time for people to unmute and ask questions directly to anybody that's speaking today. Then I will do a very short session on what is ECHO and how you can connect well with us during this course over the next 8 weeks. And then we'll end with some breakout rooms if our faculty are able to stay online with us. If not, we'll go into a final time of discussion. So I would love to be able to introduce some of our very important partners for this course that we are running. And I first will hand it over to Tebello. Tebello is representing Starlight Oasis of Hospice, and she would like to introduce a few people, and then I will call on APCA.
A very good evening to everyone that is part of this call, whether you are a faculty member or you are a participant or you are just our friends at Starlight. I want to acknowledge each one of you because this is an incredible time and moment in the health system of Lesotho, whereby we are all acknowledging that there's something that we all need to do and to improve on in order to deliver the best quality of care for our patients and their relatives. And those patients could easily be me and you the next day or next hour. So that means we have to really put the groundwork to improve for what has been a care gap that has been existing over a long time. So saying that, I really want to acknowledge that there are many individuals that have been personally part of this journey, part of the development of Starlight from 2017 when I made this vision public. But again, many that have been part of the Starlight movement as well. And there are so many of them today. And I really want to acknowledge all of them. But as Erin has mentioned, we have got many partners that have been playing a background role to be able to get to where we are. In our midst, when the Starlight community was introducing themselves, we missed out on Dr. Paul, but he will introduce himself later on. But in terms of our partners, we have got the main partner, which is our parent and umbrella body, Ministry of Health. I'm not sure if at the moment somebody can represent health, but in Lesotho language, the chief never leaves the throne or the office. So anybody that is linked, even if it's a far-fetched linkage, somebody has to represent the king. So we were expecting principal secretary to be amongst us, and as well as a non-communicable disease manager, Mema Dafita. But I've seen a couple of people from the headquarters. I've seen that Hassan is part of the Ministry of Health on the disabled, or many of them, just to see if there's anybody that can respond. But if we believe she might be late because we have got a couple of partners, maybe we can pass on to the other partners. We have got also PallCHASE, as Erin has mentioned. We have been working so hard with PallCHASE through Erin's office to make this possible. Therefore, we want to acknowledge them as our partners, and just to hear if there might be somebody just to give us a couple of words, please.
Yeah, so I can introduce, so on behalf of PallCHASE, we have Joan Marston, who is with us here tonight. She's wearing a few hats, but Joan, would you like to say hi to everyone?
Hi, everyone. It's so good to be with you today, wearing a couple of hats and to be with Erin, and just for PallCHASE to be part of this development.
And I'm representing PallCHASE, working on the Project ECHO courses. We've been able to run several courses in East Africa. We recently launched a program in Senegal for training very similar to the one that we're running in Lesotho. So it's really exciting time for PallCHASE and our education working group. We also have Annalise Otoro, who is representing PallCHASE from the Kenya team. Annalise, would you like to say hello?
Hi, good evening, everyone. I'm glad to be here and welcome all. Thank you.
And if I have missed anyone from our PallCHASE team, please do let me know. We'll get a chance to introduce the faculty shortly. Actually, I think that will be after our discussion. Sorry, we've switched our schedule around a little bit today, but there are many faculty members on the call, all kind of connected to our different partners. But the next partner that we would like to introduce, and I see several are represented here, is the Africa Palliative Care Association. It is a continental, I guess, association representing African countries, and we're really very excited that they are allowing us to engage with Project ECHO on their behalf. So we have Dr. Eve as well as Wedzerai with us today. Would you like to unmute and introduce yourself, just for everyone to see you? Wedzerai, I guess you can go first.
I thought Dr. Eve would go first. Thank you so much, Erin. I'm really excited to be here today. Thank you for the program that you're launching. We've had so many connections and interactions with partners in hospice care in Lesotho over the years, some attending conferences, some participating in different ways on the palliative care scene. So it's lovely to see Dr. Tebello taking this forward. And thank you again to the PallCHASE team. Thank you, Joan and Erin, for taking this forward. It's really, really great that you're going beyond the refugees into the rest of Africa just to try and build capacity and make sure that the palliative care agenda stays on top. And I also just want to acknowledge so many others that we see on different forums. I see Dr. Mering there. I see so many friends of APCA who are active in different ways. But yeah, just to acknowledge everyone else who's there. Thank you. Let me leave the time to Dr. Eve.
Thank you, Wedzerai, and good evening, everyone. I'm Eve Namisango. I work with the African Palliative Care Association as Programs and Research Manager. And I really salute PallCHASE for taking forward this initiative. It is really giving everybody an opportunity to learn and to take palliative care to greater heights. As the African Palliative Care Association, we really celebrate this achievement. And please, let's do more. Together we can do more. Thank you very much. And back to you, Erin.
Great. I think, yeah, Tebello was going to introduce the Ministry of Health. Joan, would you like to take a minute to introduce some of our partners in South Africa?
Yes, I'm just looking at who's here at the moment.
Yeah.
I saw, first of all, Dr. Michelle Mering, who I think is very well known in the field of children's palliative care. and she is the CEO of PedsPal, which is a leading pediatric palliative care program and NGO in Cape Town. And she also convenes the Pediatric Palliative Care Diploma at the University of Cape Town. And then I see that Delian van Jaarsveld, my friend and colleague from Bloemfontein, and Delian is a palliative care specialist, and she is leading on developing palliative care across the Free State with a very, very innovative and energetic and exciting program. So I'm just trying to see who else is here from South Africa. Have I left anyone out? Not that I can see.
Mhm.
So it's good to have a South African contingent, because we're your brothers and sisters across the border, and there's so much interaction, and we're really hoping that with this training we can increase and improve and strengthen the referral system from Lesotho to South Africa and back again.
Thanks, Joan. Tebello, I don't see, but we also wanted to strongly acknowledge and introduce the Project ECHO team. We have Dr. Leonard, who is representing the African, East African and Southern African countries, supporting as a consultant growth within Project ECHO. So he currently is based in Namibia. I don't see him on the call today, but he's been really influential and supporting our growth as a program. And Project ECHO has been in existence in Lesotho for several years. They've been doing a TB and HIV program. So we are really grateful for that, as well as Dr. Chris, who is supporting the global palliative care collaboration through Project ECHO. So I think we invited them, but they might not be on the call, which is fine, but we just wanted to acknowledge them. I think Tebello, the last one is Palliative Care Works, as well as if anyone else came in through the Ministry of Health.
Okay, thank you very much, Erin. Dr. George from Palliative Care Works is still struggling to join in. He will introduce himself whenever he's able. I think there's a connection issue for him. And in terms of Ministry of Health, I don't know if for those that are on call representing the ministry, if we haven't got Napiers on the call, or Dr. Mapota on the call, or Dr. Mpudzwe. We have got many representatives from Ministry of Health. I would like to give them a chance to say a couple of words. Okay, and while we okay, oh, amazing.
If there's no one from the Ministry of Health, I know people are starting to join, and let me say a few words on behalf of Ministry of Health, Program Director. Let me thank you for sharing the important event that marks the launch of that care training in Lesotho. No, the program and all our partners, professors, doctors, nurses, all over the world, please put aside other engagements to ensure the participate. I'm sure others will more.
I'm so sorry. I think your connection was quite poor, but it did sound like you were sharing on behalf of the Ministry of Health, which is great. So what we could probably to Tebello is during the discussion time, just do another call out to see if someone else wants to.
Yeah.
Sorry about that.
Indeed, that is Mayor Principal Secretary. So she is an accounting officer for the ministry. So she has all the rights to be talking to us. Unfortunately, the line wasn't very clear. And I'm grateful that Mayor Joan has already acknowledged the South African team, because there's nothing that we can really say without mentioning South Africa, especially because of our geographical links. those of us, because this call has got people that are potentially from different 11 countries. Just to highlight that Lesotho is a kingdom that is landlocked by South Africa in every direction. So we have got that close proximity with them in every sense of the word and currency alignment. So we have got no National Cancer Center in Lesotho. All those with a complicated and complex diagnosis, including cancer, are referred to South Africa. And we have got the connection with the Bloemfontein teams from the 2 hospitals, as well as the Majon's Hospice, simply because that is the nearest state closer to Lesotho. So they are our direct partners. I also saw that Dr. Erin has been on the call, and I just want to acknowledge specifically because for us to be where we are today is simply because of her personal effort to make it possible for me to join the APCA conference in August 2022. That conference, it was where I met Erin. Personally, we connected from the heart. I don't know, but that was meant to be. And from that connection, we have developed our exchange of conversation and how the passion is for Starlight to push the palliative movement in Lesotho. Yes, as I presented the slides, you will learn that there have been efforts before, but many of them have collapsed. And we wanted to see how best Starlight can make things revive and work with everyone that is in the space to make things possible for the patients, because there's no need for anyone to suffer when there's a lot that can really help out there. So I just want to say thank you to Dr. Michelle Mary, who really liaised with Joan Marston to make that trip possible for me. And I think, again, is just to acknowledge Dr. Tony, if he's on the call. I haven't seen him yet. The faculty members, we will come to the faculty members, but he is doing an incredible job in the district of Berea. Initially, I know they were only covering 5 villages because of the capacity they have, but that is still making a difference in the lives of those people in those communities. And I think it is just to appreciate and acknowledge. Amongst us, we have got our nursing colleagues, we have got our social workers, we have got our pharmacists, we have got our nurse educators from different we also have trust, and for that reason, maybe I might have forgotten some of the people, but we also were expecting to see Dr. Musidinyane Litsia, who played a pivotal role during the ICPCN program in 2017. Yes, some of the people, including her, might be retired, but it is worth mentioning that there's been some groundwork that was done by the team from South Africa and ICPCN in general to try and establish, at least starting with the children at the time. And the hope was that as that program continues and progresses, then there will be an advancement of palliative care in the adult community. But then here we are, we believe this is the time for us all to work together. And just wanted to highlight that the Minister of Health has been very, very much bombarded with challenges. And we have to all acknowledge as a nation that it might be now the time that we work together more than before, because they have experienced an enormous needs from the nation. We have been struck heavily by TB and HIV. You might be aware that Lesotho is number 2 in the whole world in terms of numbers, because we are a small population, but the ratio of HIV infections, it makes us to be number 2 in the whole world. That makes a big challenge. And we have got a TB as well. Now, those are the things that derailed the human resource, the capacity and needs, as well as the financial capabilities of the nation. And that was just the need. Just like we saw how COVID derailed the budgets of every institution, that they have to run quickly and get the PPEs instead of concentrating on the things that were on their strategic plans and agenda. So that is to say, that might be the reason why some of the programs collapsed. And we have to be patient and bear with them and appreciate their willingness to see how best we can work. Because for us at Starlight, when I started approaching them 2017, they really did listen to my proposal. And that was the time when we started working together. And 2018, we had the Memorandum of Understanding. I know this is a teaching session, but I thought it is worth mentioning the background behind why we are on this platform today. So I think, Erin, we will just let the program flow.
Yeah.
Maybe if Dr. George finally joins us, he will show up at some point. But thank you.
Yes, and if any of the faculty or some of the partner leads can see someone that's important has joined, of course, it's not as easy as if we were in person and we could see people join. So please do just put in the chat and we will make sure we take a minute. So now we're gonna, Tebello is going to be presenting on a bit more of that history. Of course, we know Tebello is on fire for palliative care. She could probably talk for 10 hours about palliative care in Lesotho, and I am going to keep her on track. But she's going to present for the next about 10 minutes on to understand more about the situation of palliative care. We then will go into that lecture that Joan is going to teach for about 20 minutes. And we will end the call. Hopefully you can stay on for the final part of the call, but we will end the call with more housekeeping of what is Project ECHO, how to get connected in the course, what you can do to prepare for each week. And I know we have lots of our faculty on. Again, if you're able to stay, we will do a breakout room where we will send you into, we have 77 people on the call. So of course, a large group discussion will be a bit hard. So if you're able to stay on or you need to leave for a little bit and then join, please do come back so you can help facilitate some just smaller group discussions. I'll send some questions around. So let me share my screen. Tebello is going to be speaking to us about the history and the current situation for palliative care in Lesotho. And let me know if you can see my screen.
Yes, thank you. I can see the screen.
Yes.
Over to you, Tebello, and I will keep you on track. We are definitely
Please
not on
do.
time, and I will just say, and now we'll switch over to the next topic.
Thank you. Thank you. Just do that, please, because we have already had so much time that is gone by. Yes, as it's been mentioned, Tebello Malichaba Lepheane originally, Tebello Maswabi, the mother of two, and Haisu is Smungo, the far and in the very deep highlands of Lesotho. So as we have been really collaborated with PallCHASE, with many other of their partners, it's just to acknowledge that most of the content has been prepared already. Just acknowledge the teams that have been making all that contribution, Erin and Dr. Duhedi. Thank you. Next slide, please. Just to appreciate our umbrella body, APCA having got the mission at heart to make palliative care accessible to everyone in the African continent, overseeing that all 54 countries are really committing according to the World Health expectation that palliative care is part, not just an appendage of universal health coverage. So there's a curriculum that we are following from our APCA family. Thank you. Next slide, please. The whole idea of this presentation is all about giving a background history of the palliative care in Lesotho, acknowledging and explaining how NGOs and other partners have been playing part in this journey, and definitely to identify the current situation and how best we can move from there. Thank you. Next one, please. Next slide. And that Starlight Oasis of Hope has been really under the care of our Her Majesty, the Queen of Lesotho, Mrs. Masnat Mohato. So we were privileged to launch initiative publicly for the nation last year, August, at the Royal Palace. And she really wanted us to make her statement that she likes to appreciate every faculty member, the participants, and all the partners and everyone involved in the background preparation for this initiative for that today. And she really wished everyone else all the best. The next slide, please. Here is just to mention the father of Starlight that has been working tirelessly to make this organization a charitable organization that is recognized and registered here in UK, as well as in Lesotho. We are registered. And this is Dr. Paul, who will give you a couple of words later on. Thank you. Slide, please. Here is just me when I'm not thinking about Starlight and Lesotho, that sometimes can consume my being, to think about the suffering of an ordinary person that has got no income and actually experiencing serious related health issues, and they're in pain and they don't even have money to buy paracetamol. So this is my family that had to believe first in this for me to come out and step out with a courage and a faith, because it has been a very, very long journey. Thank you. And next one, please. I think it's just to remind, especially those of us that are from Lesotho, that there's been a big document that was published as a government document in just before 2020. And in that document, there's a big statement that I always take it very close to my heart from our Majesty King Lysia III. There's a statement that he wrote there. He said, let Vision 2020 be a bond which binds us together and which strengthens our oneness, a catalyst that spurs us on a higher levels of performance and achievement. And I believe that to be the true. If we can capture knowing that if we need to be changing Lesotho for better, for ourselves and for the generations to follow, then this is the time to cooperate and work together, because there's unity in power and there's a lot of innovation and creativity. When one or more brains are together, there's more energy and exchange of ideas. Thank you. Next slide, please. Yeah, there's a big history that started around 2017. ICPCN, which is the International Children Palliative Care Network, where Joan and Professor Julia Downing, who is probably a master's, I'm not sure, and many other teams from South Africa, they worked with the Ministry of Health. And the early 2017, there was this training for about 30 people or so for the children's palliative care program. And there were many initiatives that followed. Pharmacists were accommodated in Bloemfontein hospitals at the oncology pharmacy, whereby they were learning how to reconstitute the morphine and all that. That was the journey. And following that, the theology students from our National University of Lesotho started going to Sunflower Children's Hospital for their placements to learn more about the spiritual needs of children and how to attend to them. That journey continued until on the day that I visited Sunflower to see Joan. That was early 2020, just before the first lockdown of this COVID. So they were there even on that COVID season that those trips stopped. But we have been making these efforts since 2017. And as I mentioned earlier, that was the same year that April 2017, I could not bear the burden within my spirit anymore. And I went to Lesotho that April to approach, not knowing there were already some moves of this nature. And we are grateful for all this effort. Next slide, please. Next slide. This is a picture from many articles that were published and newsletters, including eHospice and ICPCN. This is a picture of the people that were captured, that was captured on the day that they finished course. And some of them are already in the working environments, but some of them are already retired or moved on. And these are the people that Joan were training with her team. Next slide, please. We have got some stuff that we can report and mention. During that training course, there were a couple of developments, including to develop the pediatric palliative care guidelines. So on that area, we have got a document that can be used once we shake it off the dust and get going and get our legs a bit stronger to really make every child that needs palliative care to be made comfortable and to be attended to. So that document is there. It was done through their support. And we also have for this, the National Cancer Control Policy is still in the draft form. It was done in 2019. 2021 and 2022, I've been part of the meetings with the technical working group at the Ministry of Health as we were trying to edit and make it a final document. However, I think it is within Ministry of Health powers that we can take this document to a final document, but that is a big step and a big progress. So in terms of the non-communicable diseases, the document, the up-to-date document goes up to 2020, which means we need the latest document that will really incorporate the integration of our palliative care into all the health programs that we have, or whether it is cancer, whether it's the cardiovascular diseases, or whether it is HIV or any other diabetes and all that. That is to say, there's a lot that we need to do and work on to make sure the needs of this category patients are really addressed. It was exciting to me recently. I've just noticed a document published by Dr. Eve and her team. She has just said a few words earlier from APCA, which was only published this January, which is really an enormous document that we can all really work on and really put the case forward to show that non-communicable disease is still a big issue for us as Africans to deal with. And we have got also some oncology clinic where Dr. Hassan and Dr. Mpuzo and their teams are working, and Dr. Nsehe, whereby they are trying to establish palliative care services at the clinic to be able to attend to the needs of those patients as they are coming for their whether it's logistical paperwork to be done for them to go to Bloemfontein, or whether they came for the breast cancer chemotherapy that might not be need the radiotherapy. So I think it's another area to really get the services more grounded and more funding for them to be able to get everybody that they need in the multidisciplinary team, because I think the funding that covered them to be able to have for nurses and the counselors and social workers to support the establishment of palliative care services, that funding has is running out now, I think in June, this June. So that is it. Otherwise, there are a couple of patients that are now being attended and given chemotherapy under the care of Dr. Mpuzo. Next slide, please. I think this World Health Organization public health strategy for palliative care was just to highlight the many dimensions of which we needed to consider as we try and the programs. We have got all these two things to remind us that we need to integrate health services. We need to work together, including the social care, and that we know we have got social workers in Lesotho, but they work in isolation from the Ministry of Health, because we no longer have clinical social workers in the hospitals, which used to be there before 2012, when the Ministry of Health went separate ways and social development became an independent ministry. So this is a guide tool that we can access. It's a big document, but there's a lot to highlight: the capacity needs, education and training, attending to the needs of the patients with the palliative care needs and their families, and making sure we have got adequate access to essential medications, including those that are managing pain, which is still a big issue in Lesotho, as we don't have even a drop of oral morphine liquid. And then to really have for the research into establishing the facts on the ground and to really have for that evidence-based information that will support our policy change and initiatives. So next slide, please. So I think these are opportunities for improvement. I have just listed them based on using the tool that has gone on the previous slide as a mirror to the needs of Lesotho that could come quickly on my mind. Because as I mentioned, we have got morphine issues. That is why it is exciting to see our pharmacists on the call, because most of them are at the decision-making capacity. Some are from our district hospitals, and we will really appreciate to work with them. We have made several attempts to engage the ministry and the pharmacist with regards to morphine availability, to even start at tabling that concern of needing some regional and other colleagues from other parts of the world engaging. Dr. Mering, I think at some point we asked her to even deliver the presentation for us on morphine issues and the needs. And that is still an issue which we really, if we have to make a difference, it has to be felt by the patients and their families, because if the patient is experiencing that debilitating pain, the whole house is in pain. And we need to continue improving the policies and guidelines, including the one for the adults. And we have got also social challenges. In Lesotho, more than 57% of people are living below poverty line. And I'm sure if there were research that will be done post-COVID, it will even be worse. So that is to say, if somebody is unwell, then they are not even able to eat well, they lose their income. If they are working in an industry or other unsecure jobs, then it means their employers, they expel them, they lose their income, they lose their livelihood, they are unwell, they can't really cope with all those challenges. That's why we need the collaboration between our Ministry of Health and Social Development to really work together to make sure we got the clinical social workers be readily available within the multidisciplinary teams, and then we can set those palliative care teams within different hospitals so that we can attend to the needs of the people comprehensively. NCD associated with serious health-related suffering. I think it is, again, highlighting why as Lesotho, we need it now to work together as you are on the call as participants to see how we can make change and establish how we can apply these patient outcome scales to identify the needs of the patient, to identify the needs of those that are looking after them, whether they are family members or just people that are helping carers in the community. And then, like Joan mentioned in her introduction, she highlighted the challenges around the referral system. That referral system is not only cross-country between Lesotho and South Africa, it is also nationally, because if somebody is referred from a far-fetched district and there's no technology or patients what do you call it now? The patient platforms that anyone in Maseru would definitely see this patient has been referred. It's only done on the paper or in their booklet. They're likely not to even go to Maseru for all those follow-up investigations. So that is where some of the patients fall back and end up being showing at the very terminal stage when they were diagnosed with something suspicious at an earlier time. So we need to integrate all the palliative care into our existing programs and continue with the initiatives to really have for palliative and hospice services on the ground, as well as persuading our policymakers to really grant national health budget with the portion that is dedicated to palliative care, so that the education and training can be continuous. And our academic institutions, they need support as well, because integration of palliative care into the existing curriculum will help us to have those people that are ready to hit the working market, to have the basics of how to look after the patients in a comprehensive manner, as well as challenging the brokers and insurance companies who haven't even got the provision for palliative care. They only have other services, but not palliative care within their package. And anyone that needs palliative care, they are just abandoned and left out. Yeah, next slide, please. How many minutes now, Erin?
Yeah, you have about 5 minutes.
Okay, I'll try my best.
Yeah.
Okay. Yeah, palliative care services in Lesotho, as I mentioned, Sankatana is making some moves through Ministry of Health. Najojo in the Northern District at Berea, they are covering those villages through the leadership of Dr. Tony. And Starlight, Oasis of Hope, Hospice, we haven't even got a brick on the floor, but we thought whatever can be done without necessarily having the brick on the ground, we will do, which is education and training and advocacy. You might have seen the articles in newspapers, in radio presentations, television. We just want to get the message out, because knowledge sharing is the passion for Project ECHO, moving the knowledge, not people. So that is exactly what we are doing, just to inform our colleagues in the health and social sector to how we can all make changes while we are waiting for the bricks to be there on the ground. And we also acknowledge our partnership and collaboration between the South African team and all the Bloemfontein healthcare services in the 2 hospitals that take care of cancer patients and those with cases that are complex. Next slide, please. So I think it's just to leave it in our minds and hearts that as Starlight and the Board of Trustees, we have acknowledged that in order for us to all to work on the same page and to really establish some standards that will apply to make sure our services are uniform, we will have to have the National Palliative and Hospice Association. Yes, it is still in the primitive planning, but that is what Starlight Oasis of Hope is hoping to do. And we are already in advance encourage our participants that are on the call and those that will know about this call later, that just be ready. We will engage you all. You have got expertise that we can all work together. There's this African proverb: if you want to walk fast, you go alone. But then if you want to walk a little bit far, then you have to go with others. So that is exactly what we believe we can do as Starlight, to really share our passion with everyone that is willing to get on board, so we can deliver the better care for our community. So this is the future plan that we have as Starlight. We have got an app. It has gone through about 3 series of testing, and we haven't put it out into the public yet, but we hope we can use it as a referral point of system from our mobile phones by anyone in the clinic, anyone in the hospital, or even the patient. They can self-refer, or their family members, and then we'll be on the other call to assess the need and then work with those that are in our networks to see how best we can deliver care. Thank you. Next one, please. This is Dr. Paul and myself on the land that we have been awarded by the local chief, who is there next to Dr. Paul, and the local council at Matraka village. So this is where our home will be, just behind where we are standing. And this is the vision in mind that we have now, which we hope by the divine intervention, it shall come to pass so that we can all work together to make a difference. The next one, please. Just a disclaimer, this picture has been used by the permission of these family members. This was in 2017. We were with Mayor Mantabisen Tsimane, who has mentioned that she's an administrator for Starlight. She's been volunteering since 2017. And we were just going from home to home of those that we have been connected to. The cancer patients that I was able, within the 2 weeks of my time in Lesotho, every time I'm in Lesotho, even if it's 2 weeks, I would make sure I see a couple of families. So this is another family we saw. At the start of this conversation, they were facing me and we were talking. But because their pain was so enormous, they were just tearful. They had to hide their tears that were rolling continuously down their faces. So I would work hard here in England, do some extra shifts so that when I get to Lesotho, I buy some groceries, some basic needs for people to eat. You can't enter into a house of somebody that is already distressed with no food, nothing to eat, and then you come out just like that. So we would just buy with Med's money, load the car and go around and see a couple of families that we could access. Unfortunately, this lady passed on early 2018. Next slide, please. Or just to say, you don't really need to be rich or brilliant or even beautiful or perfect to make a change. But all that we need as a human species, we are born with a DNA that is full of compassion, to care, and to be the brother's keeper. So this is it. And I've come to the end of the slide, and I'm grateful with the time and being patient with me, Erin. And thank you for keeping me on my toes. And this is the quote that I would not live without saying: do all the good you can by all the means you can, in all the ways you can, in all the places you can, at all the times you can, to all the people you can, as long as you ever can. That is the reason why we are united here from different countries, from different backgrounds, to really say we want to really work with everyone that is willing to make a change. And I'm grateful for all the faculty members and all the collaborative organizations that have been willing to be with us today. Thank you very much. I think just to check if there are any questions, please.
Thank you so much, Tebello. I think that really lays a really strong foundation for this course, for the faculty to actually understand the context really well, and also as a really rich multidisciplinary group of participants for people to understand a bit more about palliative care in Lesotho. We don't have a ton of time for questions right now, but we are going to switch over to Joan Marston, who's going to be leading the teaching session today. I don't think you can be in a room with Tebello without getting some teaching. So Tebello's done a lot of teaching already, but we'll pass it over to Joan. I'll just make you a co-host. If you do have any particular questions about what we're talking about, if there's terms or things that you don't fully understand, please put it in the chat. And we have many of our faculty that are with us today. So over to you, Joan. Joan will do maybe 15 minutes, and then that will leave us 15 minutes for a breakout.
Okay, thank you so much, Erin. And I'd like you to keep me on time as well, please. And thank you, Tebello. I think that was such an incredibly passionate presentation that covered so much. And I'm sure that everybody here is now really raring to go with palliative care in Lesotho. And so I'd just like to acknowledge the education team of PallCHASE that put together this presentation, which I've tweaked a bit, and to add a little bit more about children. And just perhaps to say that my connection with Lesotho goes back nearly 50 years, when I was training student nurses at Queen Elizabeth II Hospital and examiner for the Lesotho, Botswana and Swaziland Nursing Council. And then during the AIDS pandemic, a number of registered nurses came to Bloemfontein to do a 9-month course on palliative nursing. And then, of course, in 2017, I came through to do the week's training on pediatric palliative care. And over the years, we have cared for many, many patients in our hospice programs from Lesotho. And so we have a long, strong relationship with Lesotho. And as I lived there all those many years ago, I have a very soft spot in my heart for it as well. And so today, in a very short period of time, we're going to look at some of the basic principles of palliative care. It's such a broad subject that we can only really touch on a few things, to look at the WHO definition and a few key facts and the scope. And of course, most importantly, what are our goals? Our goals in palliative care, our goals for our patients, and we're going to look at different models as well. And so the word palliative care comes from the Latin pallium, a cloak. And when I was thinking about this, I thought, well, isn't Lesotho the ideal country to talk about palliative care? Because what does that beautiful Lesotho blanket do when you wear it? It protects you, it gives an extra layer of support to the care that you're receiving. It doesn't take the disease away, it doesn't take the cold away, but it protects you. And the WHO definition, which started in 1998 and then was reviewed in 2002, says that palliative care is an approach. And it's an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness, or as we now say, serious health-related suffering. And it's through the prevention and relief of suffering that we aim and our goal is towards. And we do this by impeccable assessment, which means you have to have the knowledge and the skills and the way that we look at our patients as a whole person. The body, the mind, the spirit within the society and the culture. And very, very importantly, of course, we're looking at what is the purpose and meaning for our patients? Across Africa, there are a number of countries that are providing palliative care, and nearly all the palliative care that is provided is home-based care. It's professionals and community care workers going out into the most far-flung places to reach their patients and provide care. But as we'll see later, even though in some countries we have very good palliative care, in most of Africa, we are still lagging far behind. Children's palliative care, and it's exciting that from 1998, WHO recognized that children were different. And when we care for children, we need a different approach because we're caring from that tiny little newborn baby up until that young person with many other different types of needs across that whole continuum. And again, they talk about the active and the total care of the child's body, mind, and spirit. And we so often forget the spirit. And palliative care should begin when the illness is diagnosed. And even if the child or the adult is receiving treatment that is aimed at either controlling, like with HIV and antiretrovirals, or possibly curing the condition, like with oncology treatment, that patient can and should receive palliative care. And children's palliative care, of course, can be given in a hospital, in a children's inpatient unit, mostly in home-based care. And in fact, anywhere where a child is living, we can provide that care. And it's about life and living. Matty Stepanek, who was a young man who lived till he was 12 with a rare form of muscular dystrophy, had his own definition of palliative care. He said, it's about helping children or adults to live well and then when the time comes, to die gently. So we neither hasten nor try and stave off death. We accept death as normal, and we try to help our patients have a natural and gentle death. And you can see how the goals will change from the time of diagnosis. For some of our patients, cure is a possibility. It goes into prolonging life and providing the best possible quality. And then towards the end of life, our goals are comfort goals, helping this patient and this family to cope and to be as comfortable as possible. So why do we want to do palliative care? Well, it's estimated that nearly 58 million people are in need of palliative care across the world every single year. And most of them, going on for 80%, live in low and middle income countries. But only about 14% of people who need palliative care actually are receiving it now. So that's a really tiny percentage, isn't it? So what you're doing is going to bring you into this group of countries and individuals providing palliative care, which is acknowledged as a human right. And for that, we need the policies and the programs, and of course, resources and training. But if we look at children needing palliative care, 97% and more are living in low and middle income countries. And 52% of these children are in Africa. So we have a huge, huge responsibility living in Africa to develop our children's palliative care. And the global need, of course, is increasing. There is so much that is happening across the world. Many countries have an aging population, and so we're seeing more non-communicable diseases. And of course, we've just been through the COVID pandemic, and we're living with high numbers of HIV and TB. And Erin and I, of course, we work with PallCHASE. So we are looking at palliative care in humanitarian crises, whether it's caused by climate change, whether it is caused by war and conflict, as in Central Africa, and of course, the world's focus on Ukraine at the moment. There are many, many situations that cause a humanitarian crisis. And every single country is actually in a situation where they could potentially be part of a humanitarian crisis. And again, as I've said, we've gone through the HIV pandemic, we've gone through the COVID pandemic, we have climate change happening all over the place, and we have an increase in conflict. We have more and more people as refugees and migrants, and many people from Lesotho, of course, are migrants coming into South Africa. And that is another issue that we are looking at. And in humanitarian settings, we see a high increase in the number of children born prematurely. And that means we need more neonatal palliative care. And just to say to you that in Lesotho, it is estimated that 38% of your population are in humanitarian need. That's a huge number. And so part of what we do with palliative care is try to reduce that need within every country, and especially, so you've got a lot of work ahead of you, a big challenge. The scope of palliative care is very broad, and you're going to be seeing all these different elements that are going to be taught to you during the course of the 8 weeks of your course, and some of them will be touched on. Others, we would encourage you to go out and learn more. There is a lot of literature that is available to you, and a lot of webinars and information out there. And palliative care is a beautiful subject. It's a fascinating subject. And one of the important things, though, is we are dealing with high stress in the work situation with patients who are really ill, who are suffering, and who are dying. And so the importance of caring for yourself, looking after your own physical, emotional, and spiritual health is absolutely key for us to do this work. And who can provide palliative care? Well, everyone can get involved with providing palliative care. We can start with a palliative care approach, which everybody working in the health field and in the social care field and the spiritual care field should learn. It's the way we communicate, the way we identify patients, the way we support the bereaved. Then we have a slightly higher level, which you'll be going into now, which is general palliative care, where your skills will increase, where you might be working in hospices, in home care teams, and then the smaller group who can specialize at the University of Cape Town are those who become the specialist palliative care practitioners, and we need all levels. So our community care workers, who are absolutely key to us reaching patients, will all need to have a palliative care approach and some of the general palliative care knowledge and skills as well. And as we've said before, the focus is on the relief of suffering and the improvement of quality of life. And that brings about so many different skills. So it's not only healthcare professionals, it's social workers, it's psychologists, it's spiritual care leaders, it is creative artists bringing music and art and poetry. And we need to recognize, though, this is the patient's condition and they are within a family. And their needs and what they want must always be respected. And of course, they're within a culture as well. And so cultural respect is very important as well. And so the goals, again, relief of pain is so important. We'll touch on it now, but you're going to do far more later on. And within this short time, I can't speak about very much. But I would like to just read this quote. Dr. Balfour Mount initiated the term palliative care. And he said, after control of pain and symptoms, the most important role of the clinician is to facilitate the discovery of meaning for the patient and the family. So you can see here where he brings together the physical and the spiritual. And if we look at our traditional healers across all cultures and all countries, this is what they do. They bring together the physical and the spiritual. There are many things that people experience in the last day of life and in the last time of their lives. And these problems, as you know, are physical. Those we see, pain, of course, we see, and dyspnea, and things like constipation, which is so distressing, and nausea, and then social problems. I think living in countries where there are high levels of poverty, high levels of displacement, the social problems and the social determinants of health are often the most important and the most difficult things that we have to deal with. And then, of course, the emotions and the spiritual issues, that search for meaning. Why me? Why my child? Why my mother? And this is where religious and cultural rituals must be respected as well and can be extremely important in bringing comfort and quality to the last days of life. And so often we can see the pain, we can see the anger, we can see the anxiety. I think, Erin, there's going to be someone going to do clinical. So yeah. I'm not going to, because we've got limited time.
Yeah.
But just to say, we do use the WHO pain ladder when we are providing pain management, but the big challenge that you have, of course, is access to opioids. This is a worldwide problem, and that will be addressed in a future session. And with children, where in general, we use a two-step ladder where we go from paracetamol and ibuprofen to low doses of an opioid like morphine, and it usually is morphine, and then we increase the dose. And again, this is something that will be covered in the pediatric palliative care presentation. So when people are seriously ill, what do they want? Of course, they want their pain and symptoms controlled. They want to be comfortable. They don't want their dying to be prolonged. Mind you, some people do. They want to live as long as possible to achieve a certain goal, to see someone. They want to be in control, but they also worry about being a burden on their family. They want relationships are so important with their loved ones and with God, however they experience God. And then they don't want to be left alone. They need someone to be with them, to accompany them. And this is a lot of what we do. And there's always hope. We never take hope away. The hope just changes. And often a patient will say to me, children and adults, you'll forget me. Who will remember me? And so for Sunflower House, what we do, we say, we'll always remember you. We have a wall of sunflowers where we put the child's name, and it's in the playground, so they know that every child and every staff member will see their names every day, and they will be remembered. And then, of course, we've spoken about symptom management. It can be done in the hospital, it can be done at the clinic, and of course, most of it will be managed at home if we have the people who can care for them, and this is often a challenge, not having others to help them, but symptoms and pain in general can be managed at home, although sometimes they need to go into hospital to get things immediately under control. And these
Joan,
are just
we have
pictures
about
of
2
the
minutes.
visits.
2
2
minutes.
minutes, okay.
Thank you.
So we've spoken about the 58 million and the burden that's in low and middle income countries like in Lesotho. We can see the development across the world is mainly in the more developed countries. But if we look at Africa, Malawi and Eswatini, two very poor countries, have the highest level of integration into the health system. So don't let poverty in Lesotho stop you from integrating palliative care into the health system. They're ahead of Kenya, Uganda, and South Africa. This model is just to show how palliative care can be integrated from the beginning of the diagnosis of a life-threatening condition, and as the condition increases, so does palliative care. But there are times when palliative care is the only care from the time of diagnosis. And it can depend on access to resources, it can be for late diagnosis, and it can be with that little newborn baby with a condition that is incurable. I'm not going to go through all of this because of the limit of time. It's most effective when it's started early in the course of the illness. It reduces unnecessary hospitalizations. It helps people live actively until death. And some research has shown it helps people to live longer, and we certainly see this with children. So people die from many different conditions. As you know, it can be short-term, it can be long-term, and it can, with an aging population, go along with frailty and dementia. I think I leave the trajectories of dying because these will come out in others. And I think in the discussion groups, we're going to think of what our challenges are in Lesotho, but they're the challenges of a low-resourced country. So it's access to health resources, not having the health resources, not having the trained personnel in palliative care, having poverty. Poverty stops you getting to the health center because you haven't got the money to get in a bus or a taxi to get there. And we've recently had a baby who died in our hospice. And we were told the mother had gone back to Lesotho and abandoned the baby. The mother hadn't. She didn't have the money to go to the hospital to find out where her child was. So poverty is one of the greatest challenges that we have. And you've heard about the situation in Lesotho, what is there, and so I won't go into that. So I'm sorry I had to cut short a little bit. It was originally 20 minutes and I've reduced it to 15. But I think the discussion will come in the chat.
Thank you so much, Joan. I think, again, as Tebello laid the foundation in Lesotho, I think you also have given a really strong presentation to help our participants begin to think differently about what care means to patients with serious health-related suffering. Thank you so much, Joan. There's been some really good points in the chat. And we are going to head off as a group into some breakout rooms. So I am going to put up a slide from my computer, and I will just introduce all the faculty because you'll be heading into a breakout room with them. So we're really honored in this course to have a wide variety of faculty members. We have nurses, we have physicians, we have social workers, we have people interested in education and research. And you are going to find yourself in a breakout room with them now. So for the next about 15 minutes, we will talk about what does palliative care look like in your setting? What are your some of your hopes for this course? What are you looking at learning? And just even practice how to use Zoom. Put your video on when you're in your breakout room. You can learn how to mute and unmute. We have currently 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 13, 14 faculty, I believe, which is great. So we can have, I'm going to make 12 rooms just in case a few of the faculty drop off. But you can see our faculty members are with a hashtag, which is great. And I'm going to create each of them as a co-host. So they will end up in the breakout room. So if you had questions, please put them down in your notebook, and I'm going to make breakout rooms now. We may go about 5 minutes over because we do just want to answer any last minute questions about Project ECHO and what does Project ECHO look like. Obviously, because we have such a strong attendance today, I think many of you have attended a Project ECHO before, which is really exciting. All right, so I think I'm going to head us off into breakout rooms. Faculty, are you guys okay leading some discussion? And I'll bring you back into the group and then we'll end for today.
Hi, Erin. Yeah. I just left the chat room of the group 7.
Yeah.
Yes. Do you want the feedback, what we did or what? Like we are still with you now in the group 7 chat room.
Okay.
Okay, so the 3 faculties and other participants were there. So we
Okay.
did discuss about Lesotho and the palliative care situation about the cancer. And that was the discussion. But yeah, that's it, I think.
Great. Yeah, I think everyone else will join us shortly. Welcome back, everyone. I'm sure you didn't felt like you didn't have enough time to connect, but I do hope that you got a chance to see people and chat a bit. Great. Well, we're hoping as we get move forward with this course that we will obviously have much more time of discussion. Our first session is kind of as it is with many of our courses, regardless of where we're teaching, is really to just set the stage, to be able to understand more about the context, to meet some of our faculty, and just to get into a mode of teaching and learning. Most of our sessions will be more interactive. We are hoping to have longer breakout sessions and be able to engage on the chat and really, yeah, and allow time for everyone in the group to unmute and discuss issues. So I do want to share just the last few slides, just talking about what is Project ECHO. And if you're able to stay on for 5 minutes or so, that will be great. If you do need to leave, thank you so much for being with us today. It's been really a great program, and we're really excited that you're with us. So as again, we had mentioned, we have many faculty from many different organizations. So if you saw anyone on the call today and you'd like to reach out to them, we will be sharing contact details and email addresses. So please do reach out and don't be shy. We want this course to be very much all teach and all learn, which is a really big part of Project ECHO. We're really honored, obviously, to have all of our international and national organizations, facilities, and universities, including the partners here, Starlight, PallCHASE, APCA, as well as Palliative Care Works. And Dr. George is on the call. I don't know if anyone was in the group with him, but George, would you like to unmute quickly and wave?
Yes, thank you, Erin. And I would first of all like to apologise for the technical problems that prevented me from joining, and I do apologise, but I'm here and excited to be here and listening to the presentations. And I said, Erin, earlier about the strength of the presentations and the importance of setting the scene, the context, and setting the tone. And I think they pay tribute to the earlier speakers for doing all of that. Looking forward to working with my colleagues. We've introduced ourselves, and so, you know, just lovely to be here. Thank you very much indeed.
Thanks, George. So just so you understand, we will be doing 8 sessions over the next 8 weeks. They will happen every Tuesday at 7 to 8:30 Lesotho or South African Standard Time. We will share a video with you to watch before class. So it's usually about a 20 to 30 minute teaching video. And during the class, we'll have a shorter summary. So today, again, is a little bit different than we're normally going to do. And then we will be presenting a case. What we find is that as we talk about patients and families, we actually learn a lot. So we hope that you will be able to participate in the group discussions, whether they're a breakout room or if it's in a large group discussion. And then anytime you can put questions in the chat. You, as a group, have shown us that you are very technologically savvy. And that's really exciting because we can see that you're able to do the chat, you can unmute and mute, and it's really great. And everyone joined pretty much on time, which is good. Here's a quick schedule of what we'll often do. We'll do our introduction or our welcome. We'll do the summary of the teaching topic. We'll have our discussion time, then we'll move into our case presentation, and that will be finished by a discussion and questions. Many of you are familiar with ECHO, which is really honestly amazing. I feel like we're going to need to present the amount of people that have been registered through ECHO for this course. We literally have over 100 participants. We're only waiting for a few more to join, and it's really very exciting. This is the way the website looks. During our orientation day, we did talk about this a little bit. Each week you'll see the different topic, and then on the right-hand side, you'll see a bit of description, including the speaker. After the session today, oops, sorry. Did I lose you or did you lose me? Okay, I think I'm back. Sorry about that. So each week you'll see on the website, there'll be different content shared as a PDF. So that will include the presentation slides and any extra reading that the faculty member wants you to review. And you can download.
Recording stopped.